HBC and Health Matters with the Medicine Center Pharmacy. Now here's your host, Paul White.
Good morning and welcome to Health Matters with the Medicine Center Pharmacy. I'm your pharmacist, Paul White. We're very glad you joined us this morning. Before we begin, I'd like to thank our sponsor, Studio Arts and Glass, and of course, our socially distant technical producer, JD DeAngelis. Today, Brad and I are broadcasting from our administrative offices, and our special guest is Dr. Nicholas Bisconti, General Surgeon from Altman General Surgery. Good morning, Doctor, and welcome to the show.
Oh, thank you. Thank you for having me. It's a pleasure to be here.
Colorectal cancer is the second leading cause of cancer deaths in the United States. While that statistic is staggering, the most important information we can share is that the CDC estimates that 68% of the deaths of colorectal cancer could be avoided if all eligible people got screened. To support this statistic, the colorectal cancer death rate dropped by 55% from 1970 to 2018 due to changes in risk factors, including less people smoking, increased rates of colorectal cancer screening, and better treatments. This morning, we're going to discuss colon cancer screenings and tips for good colorectal health, along with information about robotic surgery. We'd like to remind our listeners that our program is available on our podcast. You can use your favorite podcast app and search for Health Matters with the Medicine Center Pharmacy, and please subscribe.
So, Dr. Bisconti, do I have it pronounced correct?
Yes, you do.
Okay.
Yeah, Bisconti.
Welcome to the show. Please give us a little bit of info about yourself, background training, and how long you've been practicing.
Well, okay. I was born locally. Actually, not quite locally. I was born in Youngstown. So I'm from Northeast Ohio. I've been here all my life. I did my college at the University of Akron and went to NeoMed, which is a local medical school. Did all my training in the area, trained at Akron General. Gosh, I've been practicing, it's hard to believe, 31 years now in private practice. Been doing surgery for 36 years if you count my training. So quite a long time. On a personal note, I have two wonderful children. Justin, my son, is 32, and I have a daughter who's 24. Hard to believe my kids are grown. Waiting for grandkids. Justin, if you're listening,
did either of your children follow your path of being physicians?
None of my children are in medicine. No, they're both in business and sales. So that was kind of interesting. Okay. I've been married to my wife for 36 years, and we enjoy traveling. We enjoy cooking, and just generally doing things together. So that's pretty much my story.
That's good. How many people have you operated on? Do you have any idea?
Well, when I was at my busiest, I was probably doing about 800 cases a year. So do that times 30 years.
Wow.
And we're probably talking maybe a little bit less than that, maybe 700 to 800 a year. So you're talking, do the math, 20-some thousand people maybe.
Wow.
My lifetime.
Gee whiz, that's crazy. Now, you're practicing at Altman. That's the only place where you operate, or?
Currently, we're only practice. I only practice at Altman. We also are moving our presence out into Orville. So I may be operating in Orville in the next couple of months. We're working on that. We're trying to make a more of a geographic footprint in the Altman system.
So you wouldn't be here operating, and you only be in Orville. Is that right?
No. Both places.
Okay. So there's a lot happening down at Altman, and I understand that practice is expanding, and you are going to Orville, as you said, and what would be your involvement in the new cancer facility? Is that out there yet, or don't know yet?
Well, yeah, as far as that goes, we surge and support the new cancer facility, and certainly we're the ones that do the surgery. So if somebody has cancer surgery and that's necessary, we're intimately involved in their care. We work very closely with the oncologists and the gastroenterologists. Again, we're talking about colorectal cancer a little bit here. So that would be our involvement there.
So is that facility to be an office-like building only, or it doesn't
there will be treatment, some treatment, radiation therapy, I believe, is moving there, as I recall. Mainly offices. The infusion clinic, which is therapy, will be moved there. Obviously, there'll not be major surgery done in that center. Now we're talking about the new center here at Altman.
Yeah, sure.
There won't be major surgery done there.
Okay.
So we're not going to move an operating room into that new facility.
I see. There's already a parking crush here. It's moved clear up to West Tusk. I see now.
Yeah. I was looking out the window yesterday and I see they have that whole area flattened now. So
Yeah.
We'll be dealing with that for a couple of years yet.
Okay.
Why don't we talk about some of the procedures you perform at Altman, Doctor?
Well, we're general surgeons, and I sometimes don't like that name. I get this, you're just a general surgeon every once in a while. But just to give you an idea, a general surgeon essentially do all the abdominal surgery. We'll work on the colon, the stomach, small intestine. We do all the major cancer surgery, some minor liver surgery in our case, and maybe some minor pancreatic surgery. We also do some of the simpler surgeries. We'll take out your gallbladder if you need it. Not everything is cancer. We will do your hernia repairs. We also take care of breast cancer and other cancers. And then sometimes things just as simple as minor skin lesions and that type of stuff. That all falls under the realm of general surgery. In our practice, we are also trauma surgeons. So what we're talking about there is, if you're injured, there's a good chance we'll get involved. And as I tell people, if you're a major trauma and you end up at Altman Hospital, either myself or one of my partners is going to be seeing you in the emergency room, and we'll take care of that. That's pretty much the gamut of general surgery and what we do.
So general surgery is more of a term. It really should be thought of as a kind of a jack of all trades, not necessarily just, general surgeon, right? So.
Yeah, it's funny. My wife will probably see this. She tells people I'm a trauma surgeon because that sounds more impressive, but general is a bad thing. But the thing is that I tell people we take care of the sickest people in the world. If you go in our intensive care unit, there's always 8 or 10 people who are very, very sick, and we're taking care of them. So. But that you're just a general surgeon, it kind of makes me chuckle when I hear that.
Yeah. So how about robots? We seem to like to use robots for everything from helping us dispense medications to, I don't know, if I've never seen a drone deliver a package yet, but we're told they're coming. How do you use a robot to help you improve your skill set in the surgery?
Well, yeah, robotics is an interesting field, and you're right. We're using the robot as an adjunct to laparoscopy, and I want to be very clear on my terms. Laparoscopy is when we do surgery through tiny incisions using cameras and long instruments that we can work from the outside, and we use those to guide our surgery. Robotics is a adjunct to that, where using the robot, we're able to do much better surgery. Now, I want to be very clear. A laparoscopic surgeon cannot just automatically just pick up a robot and start operating. You need a lot of specific training. I'm sure we'll get into that. But what the robot does, it offers a better operative platform during laparoscopy. And I'll give you an example. Laparoscopic instruments are rigid. They're hard to move, hard to get around things. Robotic instruments have what we call them wrists. We say they're wristed instruments. So I'm sitting at a console. If I move my hands in a certain way, the robotic hands move in a certain way. So I can sew forward, backwards, cut forward, backwards. The camera is stereoscopic, so you see things better. So robotics just opens up a whole new dimension for us. I often tell my patients, it's like I can get my hands inside of you through tiny incisions and do the operation with my own hands almost. So that's pretty much robotics in a nutshell.
How long have you been performing robotic surgeries?
Boy, I think about 3 years, and maybe 4, but about 3 years. Yeah, I think that I've been doing it. I think in our practice, it's pushing about 4 or 5 right now.
Are there certain surgeries that are more prone to being assisted with robotic surgery than others?
Well, I would say a general way of looking at it is the surgery can be done laparoscopically, it could probably be done robotically. And we are more and more moving towards the robot for all of our minimally invasive surgeries. I define minimally invasive as being able to make the small incisions that I'm talking about. So yeah, I mean, we can. We're doing with our robot, with robotic assistance, we're doing things like hernias. If you come in for me, for an inguinal hernia, it'll probably get done with the robot. We're doing ventral hernias. We're doing colon resections now. I like to do a lot of hiatal hernia surgery, and so we're doing our hiatal hernia surgeries with the robot. So anything that you could pretty much do laparoscopically, we can usually attach a robot to that.
So it sounds like you've been performing quite a number of robotic surgeries.
Yeah, almost all my hernias, et cetera, are being done that way. I've probably done, I didn't take the time to count all of my numbers, but I think in our practice, we have well over 1,000. I've probably done several hundred. And my partners have also.
Okay.
I know these robotic devices are very expensive, but are they, what are the improvements? I mean, do they continue to improve the quality of robotic equipment, or I mean, you can't go out and buy a new one every time they come up with a new improvement.
Yeah. Well, there are different platforms, and there are some platforms that are now antiquated. The current robot, the XI that we're using, has been around for a while, and that's like the latest generation. There are always improvements that you can add to it, but to add an improvement, you don't necessarily have to buy a new robot. We have 2 robots at Altman right now. But yeah, there are upgrades and things that you can get to, and upgrades in the instrumentation. The robotic instruments have changed, the things that attach to the robot, and that's where a lot of the new research is being done and developing new instruments and things like that.
I guess I've heard that
They are very expensive.
I guess I've heard they cost a million or in the millions or something like that.
We have, well, yeah, I would say you're talking about a couple $1 million investment at least to get a robot.
Okay.
And right now we have 3 of them in our system.
Wow.
1 at Orville and 2 at Altman.
Oh, no kidding. Okay. Orville's not very big, is it?
No, it's a small hospital, but it's a nice place. You know,
Okay.
they give a good quality of care at Orville Hospital.
Okay. Huh. Interesting.
How about you touch on training? I'm sure it must be intense to train on a device like a robotic tool.
Wow. Yeah, you know, it's as I said, just because a surgeon does laparoscopy doesn't mean that he can move immediately into robotics. Training involves a lot of time practicing, a lot of time on a simulator, you know, simulating real things, practicing sewing with the robot, practicing tying with the robot, getting comfortable with that. And I would probably say, I mean, when I did my robotic training, you know, we worked with the representatives from Intuitive. I mean, I can't tell you how many hours, probably 70, 80 hours or more, just sitting at a simulator practicing. At night when I'd be on call, I'd go down, turn on the simulator and start practicing with the robot. After you get those basic skills down, then you have to go and you want to get your hands on live tissue. Well, obviously, I'm not going to start on a real patient. So there are laboratories that we go to where we operate on cadavers, and then you can get you have what you call your basic robotic training, where you can do things like a gallbladder, maybe some simple hernias. After you get proficient with that, then you have to add more advanced training, and where you actually expand the use of the robot into the more advanced, more technical surgeries. And that's a whole separate course. And to be honest, we're always learning. And you need to be certified, and you need to pass basically that course before you can start, you know, performing robotic surgeries at the level that you want to perform them at. So there's a lot of training, hundreds of hours that go into this.
Wow. Okay, Doctor, our first break's here. You're listening to Health Matters with the Medicine Center Pharmacy. We are back, and Brad and I are discussing colorectal cancer screenings with Dr. Nicholas Biscotti, general surgeon from Altman General Surgery, but his wife likes him to be called trauma surgeon. Is that correct?
Yeah, she prefers the accent. Sounds more impressive. Yes. Yeah.
Okay. All right. Well, that's cool. That's cool.
Ask him if it means, you know, if the robot does all the work and you don't do any of the work. But
Yeah,
I think we've kind of covered that. So
No,
Who needs a surgeon?
right. No, the robot is at my command. It listens to me. You know?
Do you ever see the day when the robot will be doing the surgery alone?
No. I certainly, you know, I never saw the day when we would have a plastic card that was equal to money, you know, when I was young. But
Yeah, sure.
you know, I can't say absolutely no. But there's a human element to surgery that will never be replaced by a machine. It'll always be under the direction of a surgeon. Yeah.
Interesting. Okay, so during surgery, where are you in position to the relation of the robot?
Well, that's interesting because there are phases. In the first phase of the surgery, we still have to put all the tubes in that we call trocars that our instruments go through. And in that situation, I'm scrubbed in, standing right over the patient, doing that part of the surgery. Then we have what's called the docking phase, and that means that's when we hook the tubes up to the robot, and then we insert the instruments. And I'm still at the patient's bedside then. After everything is set up, then we go and we set up what's called the console, which is what I'm using to control the robot. And I'm usually, if you're looking at the foot of the bed, I'm on the left side, and in a little console, I'm probably no more than 4 or 5 feet from the patient at any time.
I've seen pictures of a robot over a patient. It looks like an octopus.
Yeah. It's kind of scary looking when you look at it, isn't it? Yeah. It's like, all these arms and tentacles.
How do you get out of its way, or how does it get out of your way, or whatever?
Well, we have it's basically, like I said, it's at our command. We can move it any place we want to move it. So
okay. Amazing, huh? So you've been a surgeon for a long time, and how do you make that transition to robotic surgery? Did you fight it? I mean, I'm better without the robot, or
yeah. It took me, and I think I think some of my partners would say the same thing. It's why do you need a robot? We do laparoscopy. Why do we need this and need that?
Sure.
But initially we fought it, but I could go into the story about how I became more convinced if you'd like me to, but just seeing what was going on and seeing how I thought it really would make the surgeries easier once you managed, once you were able to gain some of the skills you need on the robot, and I became convinced.
I sort of see.
Go ahead, please.
I sort of see that robotic surgery as. Have you ever heard of a pantograph? Where you trace with this one 2-arm device or something, a small template that makes it bigger, or
exactly.
It's not exactly the same thing, but that's what I first thought about when I heard the robotic surgery was coming into play.
Right. There may be an analogy there. What I tell people is that I'm sitting at a console, and if I move in, the camera moves in. If I move back, the camera moves back. If I move my hands apart, the robot's hands move apart. So the robot is doing nothing but magnifying what I'm doing in my small console inside the patient, which is why I gave the example earlier. It's almost as if I have my hands in there. Obviously, my hands would be very large. I'd have to make a large incision, but the robotic instruments mimic the motion of my hands and my body while I'm doing the procedure.
It
that makes sense?
Yeah. Well, yeah, but it's just hard for me to see this as an improvement. But I guess the robot doesn't shake or is steady or steadier than the surgeon. Would that be a correct way to put that?
Well, no, I think that any surgery that we can do with the robot, we can do via an open technique. I mean, we can open somebody up and do it. The improvement, I think, is over laparoscopy, making it a lot easier. Okay. I will say one thing about the robot, and what convinced me that robotics was actually where I wanted to go is I got called into a robotic case being done by a gynecologist to look at some anatomy that this person wasn't sure about. It involves intestine, which is not in their field. And I looked at the picture. I sat down at the console and I thought to myself, "Oh my God, I've never seen this well." And that's when I started thinking maybe there is something about this. Camera up close. It's more of a stereoscopic camera. You get more of not a true 3D image, but you get a more what we call stereoscopic image. And I just looked at that one experience. I said, "That is real. This is really amazing. I can see this better than I've ever seen it in my life." And that's what prompted me to start looking into robotics. Really.
Do people say no? I don't want this robotic surgery.
Very rarely, because when I present this to patients, I present robotics as an adjunct to laparoscopy. So if you need a hernia done, I'm going to do it laparoscopically. It just makes sense to have the robot if it's going to make my life easier. I've never had anybody say no. I don't want you to use the robot.
Okay.
I guess it could happen. Sure.
Well, it's interesting. I just with the suspicion in the people, a la medical community, is this right for me, or is this good, or that sort of thing. So, but you've been doing this it's been around what, 10, 15 years? Is that about right, or longer?
We've been doing what the robotics?
Robotic surgery, yeah.
Robotic surgery's probably been around. Yeah, I can't give you an exact number, Paul. I'm thinking, I'd say probably about 20 years. Yeah, okay. Yeah. Now we haven't been doing it that long, obviously, in my practice.
Sure. Interesting. Huh.
What about some risks? Any extra risks using the robotic assist?
Well, any surgery has its share of risks, and the risk of any surgery is the risk of getting into bleeding, the risk of getting into uh, an organ that you don't want to get into, injuring something you don't want to injure, and then later on risks of infection, et cetera. And really, the risk with the robotic platform is no greater than any other platform surgery. I would say that if you do get into some bleeding and stuff with the robotic platform, since you can see so well and get in there, it may be easier to get the bleeding to stop than it is with a straight laparoscopic approach. So no, I don't see any increased risk, but there are risks to any surgery. And your surgeon, when he interviews you and you consent to surgery, has to go over those with you.
It is the bottom of the hour, time for the news, and you're listening to Health Matters with the Medicine Center Pharmacy. Welcome back to Health Matters. This morning we are talking with Dr. Nicholas Visconti, and we're jumping around on talking about surgery.
We haven't really talked about it yet, but I'm sure that with smaller incisions, you get patients home faster and you probably get fewer complications on some level. Would that be fair? And what kind of procedures do you see you and your colleagues using robotic assist for more now than you have in the past?
Well, certainly, where we're seeing a big difference in outcome is in a lot of our intestinal surgery, bowel surgery, and things like that. Patients who had large incisions now are getting smaller incisions, and they're going home actually very quickly. Some on the first post-operative day, which is almost unheard of.
Wow.
And so we're seeing a lot less pain and discomfort in these patients. And I'll even say in our less I don't want to say smaller surgeries because every surgery is important, but say even in our inguinal hernias, we're getting patients home, and patients that would take a month to 6 weeks to really be back to work and regular activity are really back to normal in about 2 weeks. So we're seeing a lot less in the way of pain. Our infection rate is low. I can't give you an exact number whether it's lower than with an open incision, but we're really seeing a decrease in pain and a decreased hospital stay for patients.
Well, I'm sure that's welcome on all sides. I mean, the patient loves it because they get to go home faster. They don't have to suffer as much, and the insurance company doesn't have to pay as much. So it's a win-win-win. Well, great. Do all the surgeons in your practice perform robotic surgeries?
Yeah, all but one. And the only reason he doesn't is because he's getting ready to retire this year, we think. So he's not going to go through the training, but yes. And it doesn't matter who you see. We can direct you to the appropriate surgeon for that procedure. If it needs to be done robotically, and we'll make sure that you get taken care of.
All right, you've touched on laparoscopy a couple times in our discussion, but it's not the exact same thing as robotic surgery. Is there a difference in recovery times?
Well, it's interesting, and that's not as easy a question to answer as it seems. When you look at major studies that are being done, they come out with that there's no real difference in recovery time for these people. And when you look at they're looking at like the amount of pain medicine used and stuff like that, it's not much different. But that's not where the key is. That there are certain unmeasurable things that we see. So even though a patient might say, "Yeah, I use my pain medication for 3 days," when I see them in the office after a robotic procedure, they're saying to me, but the pain wasn't as bad. It wasn't that bad as compared to my laparoscopic people. So there are some intangibles that we can't measure. And I don't know what the reason is. I think that maybe because we could be a little bit more precise in some of our dissection, that maybe there's not as much tissue trauma. But I am seeing a definite difference in the amount of pain my patients are having after robotic surgery, as opposed to obviously open surgery, and even after some of the laparoscopic surgeries. Absolutely.
Well, how do we maintain these devices? I mean, there has to be extensive maintenance, cleaning, sterilizing, whatever. Is that a big task?
Well, it's a big task in any part of surgery. We have to sterilize all of our equipment. Obviously, the technical aspects, we have a maintenance contract, and these machines are taken care of by technicians that know what they're doing, basically. I will honestly say I've never had a robot fail during a surgery. That would be an interesting thing.
Yeah, I never thought of that. Have to change the tire, huh, or something
Yeah,
like
yeah.
that.
And if it did, it would be the end of the world. Would handle it, but
Yeah,
I've never
yeah.
seen that happen. Yeah.
Okay.
Okay.
Okay. So March is colon rectal cancer awareness month. Um, what would you recommend for good colorectal health?
Oh, really? That's a healthy diet is the main thing. Exercise has been shown to help. Maintain a good weight. And basically, avoid smoking. Smoking seems to for some reason be connected to these diseases. And also, get your screening when appropriate. I mean, those are the things that you need to do, and that's pretty much it. I can get more specific as you ask more questions, but that's the
Yeah,
general
sure,
template. Yeah.
sure. Early in the program, I think we mentioned that it's down significantly. Is that correct?
Yeah, the
Colorectal
death
cancer.
rate is down, and for a lot of reasons, but one of them really I can't emphasize is the screening that we're doing today.
Sure,
Absolutely.
sure. So, okay, how about diet recommendations? Just vegetable diet, a beef diet, pork diet. I mean, what do we want?
Yeah, yeah.
Yeah,
You know,
what do we want these
if,
people to eat? I mean, I don't think
yeah.
I'm hearing people
If,
who go and eat several hamburgers a day and buy one for the dog at the same time.
yeah.
Uh,
If you want to get into a controversy and you want to get into something that's going to change in a couple of years, start talking about the best diet you should be on.
yeah.
Absolutely. But it's a general consensus. It seems to be that a diet that's high in fruits and vegetables, high in dietary fiber, low in red meat. Doesn't mean you can never eat red meat. That's not what I'm saying.
Mm,
Maybe higher in fish and more lean meats. Is probably the best kind of diet. And then also there seems to be a link from what we can see in the epidemiologic literature between excessive alcohol intake anyway and colorectal cancer. So I just tell people limit your drinks to a couple of drinks a day if you're going to drink for colorectal health. That's pretty much the recommendation at this
mhm.
point in time.
What about testing? The number I hear is every 5 years on a colonoscopy. Is that about right?
The actual recommendation is every 10 years at this point.
Okay.
Yeah, starting at age 45.
And
Uh,
they're still using the I can't recall the name. Used to do it in the drugstores, hand out those cards. Um, Shoot, what's it called? Brad, help me. I can't.
we're talking
Are you
about
talking about the home test kits that you
Yeah,
can use
yeah.
in the
You mail
commode?
in, that sort of thing.
the fecal occult blood
Yeah,
tests,
yeah, called. Yeah, that's it.
hemocult
Okay.
tests.
Yeah,
Yeah,
we have.
thank you. Yeah,
It's kind of
yeah.
been quiet lately on it because years ago it was big time.
Yeah. Well, there's a significant false positive rate with it. And my family physicians may be using it. Yeah, and that's where most of the screening is done or ordered is through their offices.
Sure.
Absolutely, and that's important.
So, what's your opinion on the Cologuard?
Well, Cologuard for the our audience here is basically where you mail in a stool sample. You need a prescription for it, and what they do is they're analyzing for abnormal, what we call DNA, maybe mutations in DNA that might be indicative of a malignancy. Okay,
Hmm.
and Cologuard is pretty good at picking out cancers. I think the last numbers I saw were somewhere about 94, 95% of colon cancers will be picked up by Cologuard. I think where Cologuard's shortcomings are in that it'll only pick up about 42% of large polyps. And the idea of screening, I mean, what you ideally want to do is you want to pick up benign disease. Polyps can turn into cancer, certain types of polyps can. You want to pick up benign disease before it becomes malignant. That's where you really have the best impact to save lives. And so if you're looking at a test that is about going to miss large polyps maybe 60% of the time, it's not going to replace colonoscopy. My opinion on Cologuard is that if you want to use it as an adjunct to your screening in between colonoscopies, say like every 3 years, they say maybe get a Cologuard, and that's a whole different story. You're not relying solely on Cologuard as your only means of screening. And I guess there may be a place where, if for some reason in remote areas where there's not access to colonoscopy, it's not readily accessible, et cetera, which I can't think of many of those in the United States right now, it may be something that's very valuable. But as the primary screening test for colon cancer, no, I still think we have to fall back on colonoscopy. And to give you the other side of that, colonoscopy will pick up 95% of all of them. Nothing's 100%.
Sure. Okay. Interesting.
All right, doctor, one of the things we haven't talked about is we've talked about where you practice at Altman and maybe a little bit in the near future at Altman Orville is how did the listeners who have been inspired to make sure they are in touch with their colorectal health find out more about you and your practice?
Well, if you need an appointment, obviously you can call us 453-4300. We're on the internet and the phone book. If you would like to look up us on the internet, look us up on the internet. I'm sorry. Just look up Altman General Surgery, and if you Google that, you'll come. The first thing that comes up is usually our website, and it talks about us. So that's how you get in touch with us. Obviously, if your family physician needs you to see a surgeon, we hope that they consider referring to us, and we do accept referrals, from your family doctor also.
Is it common that you need a primary care physician to refer you to a service like yours? And I guess if we're speaking in the terms of colorectal health, if you have a concern, we haven't really talked about it, I don't think today, but I'm guessing that, if you see blood in the stool or you see some discoloration in the commode, that's certainly a concern, and you should reach out to your primary care provider or a specialist like yourself. Any tips for listeners on, is there anything you can see, or is it really just the colonoscopy that's the most important screening tool in this day and age?
Well, yeah, I think at this point in time, the colonoscopy is the most important screening tool. And remember, screening is really, really done in people who are asymptomatic. In other words, you come in, the current recommendation, I believe, from the American College of Surgeons is to get screened with your first colonoscopy at 45, and if it's negative, every 10 years. If there are polyps, depending on the type of polyps, et cetera, we may shorten that interval. We do not do, I take this back. Only one of us does colonoscopies in our practice, and he does those out of Orville. So we can't arrange for you to have a colonoscopy in our practice if you need it. Remember, if you see blood in your stool, that needs to be looked at. If you have hemorrhoids, don't always blame it on your hemorrhoids. You have to make sure there's not something else going on. So when you have a symptom like what we call hematochezia, which is blood coming out of the rectum, if that needs to be investigated, and don't hesitate to call your family physician, get in to see him or her, and get the appropriate screening done. They can refer you to us, to a gastroenterologist if necessary, and we'll make sure that gets taken care of. Absolutely.
In my listening to people over the years in the pharmacy that are going to have a colonoscopy, I commonly hear that, gee, I can't eat tomorrow, so I'm going to have a big meal tonight. Okay. and I'm thinking, in my case, I've had 2 or 3 colonoscopies. I'm thinking, I'm not going to eat anything for a couple of days before, or liquids or something like that. And it just kind of slays me that people either haven't been told or they eat light or liquids or whatever, that it'll just make things worse. So what do you tell these people?
Well, again, we don't do colonoscopies routinely in our practice, except for one of my partners.
Oh yeah, that's right.
I'm not sure what prep he's using. I know when I had my colonoscopy, I had a big meal the night before I started my prep the next day.
Not good.
And I was fine. So I would just say, follow your gastroenterologist's recommendations. And there are many different types of preps that we're using today. And do whatever they feel is best.
It's just,
there's even a recent article that questions whether we needed to have only clear liquid.
My philosophy is the more in, the more that has to come out, so before
exactly.
the test,
so
it just doesn't make any
and
sense.
I will point out that's probably the worst part of a colonoscopy is the prep.
Yeah, for sure. Itself, and they've been bouncing around for years now on what to use and what not to use.
Exactly. There's many of them out there, as you know.
Yeah, so one of the products, I think it was Fleets, that they kind of banned from some reason, and I can't remember what the real deal was on that. Some toxicity level or something, but that was banned a while ago. So.
Yeah, we're not using that as much, especially like in renal failure patients and things like that. Yeah, absolutely.
It's time for our last break.
Oh yeah, it is. You're right. Okay, you're listening to Health Matters with the Medicine Center Pharmacy. technology has just exploded in the 50 years ago or something like that was when that happened to me, or maybe 60 years ago.
Yeah.
So
No, you're right. Technology has exploded, and a lot of things that I do today, we do with a lot less blood loss and
mhm.
that type of thing than when I was in my training. I hate to say how long ago it was, but 35 years ago when that started. We have a lot better methods of hemostasis now, which means stopping bleeding through various types of instruments that we have that cauterize better. The amount of blood that we lose in surgery today is, in my opinion, far less than it was when I was in my training, where you had to basically clamp, cut, and tie everything. There was more room for tissue trauma and things like that. And a lot of this is being put into a minimally invasive platform. There are just huge advances in technology that make my life a lot easier in the operating room. And I always tell people, when my life is easy in the operating room, your life is easier post-operatively. We have less chance of complications and things.
Sure.
And that a lot of the advances in surgery that we're seeing that have made surgery a lot safer is really not based on the skill of the surgeon, because we have always had very, very skilled surgeons. But surgery had to be done within the limitations of the platform that we were using. And as instrumentation has gotten better, I have seen patients improving more quickly, and we can do a lot bigger surgery on people at a more advanced age, and they still have a good outcome. So that actually is a very good question, but we could talk about many, many different things.
So what you're saying to me is that you're not using as much blood transfusion. Is that correct?
I don't think we are. No. I can't give you, a personal history about the amount of blood that I lost, but surgery per surgery. But we're doing a surgery in a much more bloodless fashion, and that's really based upon the technology that we have for hemostasis. Hemostasis, means stopping blood loss, stopping bleeding, basically, and that kind of stuff. So, surgery has changed a lot in the 35 years I've been doing it.
Do you use expanders or just blood transfusion if needed?
Usually blood transfusion. Yeah, we have some experience. Usually just transfusion if we need it, but we rarely have to transfuse patients after surgery anymore. We don't give much blood to people.
No kidding. That's really amazing. Wow.
Any parting comments you want to share with our listeners about colon rectal cancer awareness month, doctor, before we wrap up?
Well, I think we talked about the most important thing is screening. And if you're due for a colonoscopy, don't fear it. Get your colonoscopy done. If your physician feels that Cologuard is what you should do, maybe you're in between colonoscopies, they want to check one, don't be afraid to do that. The main thing I want to impart upon people is in the middle of this pandemic, don't be afraid to seek care. We screen everybody before they come in the office. You get your temperature taken. We limit the amount of visitors people can have. And we have a very, very safe environment in our office, in all of our offices, and at the hospital. I think you're probably safer coming to the hospital to get care when it comes to COVID than you are going out, to going shopping. I really do feel that it's very safe. And I just don't want to see people not get necessary care because they're afraid to come to the hospital. Get your care, get done what needs to be done, and everybody will do fine, I promise you. That would be my parting words in that.
Okay. Thank you very much, Dr. Nicholas Visconti, General Surgeon from Altman General Surgery. We'd like to remind our listeners, if you suspect you have a medical issue, please contact your healthcare provider. Thanks to our sponsor, Studio Arts and Glass, and of course, our technical producer, J.D. DeAngelis. As always, we thank you, listeners, for joining us on Health Matters with the Medicine Center Pharmacy. Have a healthy week, and we'll see you next week right here on News Talk 1480 WHBC.